Hi, I'm Dr. Scott Laborowit. This is a video demonstration of an incomplete capsulotomy during femtosecond laser-assisted cataract surgery. I had a gas bubble at the interface I thought would cut the capsule through the bubble. But you can see starting at 12 o'clock, I start to lose the visualization of the complete capsulotomy. It extends about 2 clock hours. So I filled the eye with viscoelastic, and then I like to scoop under the capsule, and as I pull I can see it's really somewhat stuck to the peripheral capsule. It's hard to distinguish cortex and capsule, so by going under it I can look for the stria of the capsule to know and distinguish the tissues. So now I'm very suspicious that there's a bridge, so I'll go in with the Eutrata next. Here's a zoomed in red reflex showing that the capsule is starting to tear out. I enter the eye with the Eutrata. What's nice about FLACS is in these cases you can always take a step back and resort to your traditional surgical techniques. I left this unedited so you can see the struggle and how real it gets. Trying to grab the capsule, the red reflex isn't great because of the cut cortex, the 24 cuts in the lens, and as I'm trying to use almost tactile efforts to grab the anterior capsule and go in a clockwise manner, you can see I really just don't have much success. I'm even using the tips and tilting them. I started to distort the cornea some a little in this case, and I'm very careful to make sure that I'm maximizing my visualization. Again, I just want to make sure you have the unedited version so you can see. And at that point, I decided to go from the other side, and I was able to a little more easily visualize it. It's really important to make sure when you do manually create a capsulotomy that you go outside of the intended laser capsulotomy in case there is some cuts. And you might see, if you look closely, that I may have not gone outside to connect to the final piece. So I kind of zoom in, but I'm not going to go back and mess with it at this point, but I'm going to tiptoe in this area at 11 o'clock. But I'm not certain I went outside the intended capsulotomy to reconnect as I went clockwise. I do not hydrodissect. I use viscodissection to the equator and use the air bubble from the femtosecond to allow for pneumodissection posterior. I'm trying to stay away from the area a little bit where I think there might be not a complete continuous capsulotomy. Next, I'll go ahead and do the phacoemulsification. There are other videos that show how I do a different technique in FLACS, and I believe there's much less stress on the bag during removal of the nucleus in FLACS, which would be beneficial in these cases. Here's a picture after the lens is removed, great red reflex showing that indeed I did come inside as I went counterclockwise and did not fully connect. So there is a little bit of an incomplete continuous capsulotomy. I leave the viscoelastic in pretty full and place the IOL in the bag, but then I'll go in with the Eutrata again, and now that I have great visualization, I can grab this little tag. I'm utilizing the little technique to pull towards the central visual axis, allowing it to tear and create a continuous circular capsulorhexis. This way I did not need to worry that there could be an extension of this while I remove viscoelastic or the IOL haptics stretch out inside the capsular bag. I also have a presbyopic correcting lens, so I want to assure great centration long term as well for the focusing piece. This is a zoomed in area showing it is now continuous after the little technique was used. An uneventful case, and fortunately recognizing it was the key. Thank you.